Okay, so we are moving on to the surgical management. Craniotomy. Craniotomy. Right. Sometimes you come across craniotomy and craniectomy. They are two different things, even though they are all surgeries that is done on the brain. With craniotomy, right? So let's take it that this is the skull, right? And then if you have any injury to the brain, example is, or any condition of the brain like brain tumor or injuries like subarachnoid hemorrhage, subdural hemorrhage, the surgeon can make an incision through the skull, right, and then correct the deformity, right? So the process whereby an incision is made through the skull to correct any deformity, being it removal of a cancer cell or draining of blood, etc., is what we term as craniotomy, right? But craniectomy is where only a part of the cranial bones, you know that we have the several of the cranial bones, right? So if only a part of the cranial bone is removed, that is what we term as craniectomy, right? So as I said, craniotomy refers to any surgical opening in the skull to correct a deformity, right? And then whilst craniectomy is an excision of part of the skull for exploratory purposes. So sometimes it's not even, the craniectomy is not even done to correct a deformity, just to take a biopsy of a brain tissue for analysis, right? Okay. And then cranioplasty, right? Always when you hear of plasty is a repair, right, instead of removal. So cranioplasty is a type that, or is a type of surgery done to repair a bone, right, by using prosthesis, etc., right? So it's a repair of the cranial bone. That is what we term as cranioplasty, right? But because it's on the brain, it begins with the cranial. So you either have craniotomy, craniectomy, or cranioplasty, right? So craniotomy is an incision into the skull, whilst craniectomy is where part of the cranial bone is removed. It can be used for diagnostic investigation. And then cranioplasty is a repair of the cranial bones. Okay, what are the indications for craniotomy? Why will a doctor do craniotomy for the patient? Most of the time, if you have brain cancer, to prevent it from spreading, you can do craniotomy. So cancer of the brain. Cancer of the brain. When sometimes it's done for diagnostic purposes, as I said, if the doctor wants to get a brain tissue for analysis, so biopsy of the brain tissues, a craniectomy can be done. And then sometimes if there is either subarachnoid hemorrhage or subdural hemorrhage, craniotomy can be done to drain the blood. And then if there is a fracture of the bone, sometimes to repair the fracture, which we term as cranioplasty, the one I talk about, you can also do surgery on the brain. And then repair of aneurysm, right? You can have cerebral aneurysm, where I said that the last time that aneurysm is where there is a weakened part of the vessel, right? So sometimes there is a blood collection in that weakened part, right? And it has to be removed, right? Otherwise, when it's ruptured, it can lead to hemorrhagic stroke, right? So aneurysm can also be excised through the process known as craniotomy, right? And then to drain abscess formation of the brain, right? So in these cases, craniotomy can be done. In these cases, craniotomy can be done, right? So normally you have to prepare the patient for the surgery, right? And then even the name alone, telling the patient that you are going to have surgery on your brain alone can make the patient anxious and depressed. So it means that you have to prepare the patient psychologically for the surgery, right, as well as the family members, right? So you have to educate them on the condition, the surgery, the need for the surgery, right? And most of the time you have to tell patients and their relatives that is the only option, right? So sometimes they will want to know whether there are medications to treat the condition. So the only option is the surgery. And because, especially if it's cancer, because it's cancer, if it's not done, it can spread to other organs and then lead to other complications. So you have to explain to them for them to get it. You have to establish rapport, right? You have to assess their level of anxiety, right? And then you tell them to express their concern so that you know what is they are worried about, and then you have to address those concerns appropriately. And then you have to also find out what the doctor has told them so that where necessary you can add, or if you think that the patient need to be educated well, you have to refer the patient to the doctor, right, so that the doctor can educate the patient before the patient signs the consent form, right? So you have to also explain some pre-op procedures, right? Because if, let's assume that the patient is a female, you are going to shave the hair, right? And look at how women value their hair. So you have to really explain to them the need for their hair to be shaved and all that, right? You pass catheter, why are you going to pass catheter and all that? So all this should be explained to the patient. Where sometimes NG tube may be passed before the patient go for the surgery, right? So all these pre-op procedures should be explained to the patient, and then the reason why these things will be done. And then sometimes you have to tell the patient about the equipment or the theater, how the theater looks like, and then some of the equipment you will see in the theater, right? Just so that the patient does not get anxious when he or she enter the theater, right? Most of the time we say that you take the patient to the theater, but we know that most of the time patients only see or enter the theater when the patient has signed the consent form and then the patient is going for the surgery. Okay, so you tell patient about some pre-op procedures and then some post-op procedures like wound drainage tubes, right? So that if patient regain consciousness and see a tube inserted through the head, the patient will not be anxious because we've already pre-informed the patient about it and the reason for those things, right? And you have to also teach patient about some exercises like passive exercises, deep breathing exercises, and those things, so that after the surgery, the patient can be performing all those things, right? Okay. And then you can introduce patients to other patients who have undergone the same surgery, and then they are coping. So family and relatives to other patients who have undergone the same surgery, where the patient wants the pastor or a chaplain or whoever to pray for them before they go for the surgery. You have to allow that. Family support, you have to let the family members come around, encourage the patient and all that, right? And then economic support, where most of the time surgeries like this is very expensive, so you have to find out how the patient will cope, will afford, right? How the patient will pay for the surgery. And if patient cannot afford, you have to find means of helping the patient, right? Whether you contact some family members, the church or whoever, or the social worker or whoever, to help the patient to pay for the surgery, right? Physiological care is not different from other physiological preparation. So vital signs should be done. And then we are talking about hemorrhages in the brain or cancer. So assess the Glasgow Coma Scale, the level of consciousness of the patient, right? And you have to also assess the respiratory function, right? Your baseline vital signs should be there. Fluid and electrolyte balances should also be monitored, and then other lab investigations like full blood count, WBC. So you are looking at the HB, the WBC count, and all that, so that appropriate intervention can be done before patient goes for the surgery. And then you also have to assess for the renal function and all that. So it means that you have to do urine RE and the rest. So you take urine sample to the lab. You assess for signs like headache, the level of consciousness. I've talked about that, right? So you do all these things. The hydration status should be assessed. The nutritional status should be assessed. So it means that you have to monitor the weight of the patient, right? Before, and then nail per os, 6 to 8 hours prior to the surgery. And then if IV fluids have been prescribed, especially if you are giving osmotic diuretics have been prescribed, you have to start it. Okay. With the physical preparation, we have some that are similar and then few additions. So let's look at the addition. The general ones, I will not talk about it again. So with the additions, because it's the brain, the washing will be done on the hair, right? So you wash the hair with soap and water, right? And then you shave. So you have to shave the hair on the scalp, right? And then you apply a scarf on the head, right? And then you also ensure that diagnostic investigation like CT scan, head CT scan, MRI, etc. is done, right? And the results is ready. Most of the time, the surgeon wants to see if it's a tumor, where the tumor is and all that. So make sure the results is ready. So if you are sending the patient to the theater, you should accompany the patient. The results should be accompanied to the theater, right? So that they can, because sometimes with some theater, they will not even accept the patient if some of these things are omitted. So you have to make sure they are all ready. And then you have to monitor and manage seizure if where necessary, right? And you give prescribed pre-med like anti-seizure medication, diuretics, corticosteroids, etc., right? And then depending on the condition, if it's head injury and there's fracture, skull fracture, then you can assess for signs of CSF leakages through the ears, the nose, etc., right? And you know how to, if you want to be sure whether it's CSF, then it means that you have to test the fluid for or the drainage for presence of glucose, right? And then you suction where necessary, administer oxygen where necessary, even before the surgery. Even sometimes blood transfusion can be given before the surgery, right? Monitor SpO2 and all that, right? Apart from that, all other general pre-op physical management can be done, right? With the post-op management, just like any other post-op management, assess the level of consciousness, right? To make sure you are receiving a live patient, and then you have to get the notes, the anesthetic notes, to know whether which position to place the patient or the medications and all that, whether there is any special guideline, right? And then when you admit patients, it depends. Sometimes the patient will be monitored at the ICU, so the patient is conscious before the patient is brought to the ward. But if the patient is unconscious, you know which position to put the patient. If patient is conscious, you can put patient in low Fowler's position, right, to reduce the edema and then reduce or prevent increase intracranial pressure. And then you have to assess the incision site, right, for bleeding, right? If the bleeding is excessive, you have to report, right? This one, don't reinforce, right? You are talking about craniotomy. Most of the time, some of the surgeons will even want to come around to manage the patient for some time because of how serious the condition is, right? And then if a wound drainage tube is present, you have to assess for continuous drainage the site of insertion for bleeding, right? And then make sure the patient is not lying on it. The bag where the fluid is draining into is below the patient, not on the bed and all that. So check for continuous drainage, right? And then you suction the patient where necessary. You administer oxygen where necessary. You assess for signs of increased intracranial pressure, right? Monitor SpO2. Assess for CSF leakage from the site, right? And then if it's present, you report. And then signs of increased intracranial pressure. Assess patient ability to move the extremities, right? So you not only check vital signs every 15 minutes. You are because it can surgeries on the brain can affect motor activity. So you have to assess the ability for patient to move extremities every 15 minutes, and then you can move on to every 30 minutes, and then every 4 hourly, right? And then you have to provide safety. So your side rails should be up, and then because patients can be unconscious and all that. When they are regaining consciousness, sometimes they become restless. So you have to ensure or provide safety, right, by raising your side rails. And then you have to provide warmth, right, because if the CNS, if the hypothalamus is affected, it can affect the temperature, right? So you manage high temperature where necessary. If patient is feeling cold, you provide warmth by covering the patient. And then you have to avoid unnecessary movement of the head, right? So it means that you have to maintain the head in neutral position, ensure a quiet environment, right? The drain, if it's a hemovac drain, it can either be a hemovac drain or a Penrose drain. So most of the time with the craniotomy is a hemovac drain, right? So whichever drain is being inserted, you have to manage it appropriately, right? Straight intake and output should be monitored, right? If there is periorbital edema, right? So there is edema, periorbital edema, you can use ice packs around the eye to reduce the edema, and then encourage patients to engage in deep breathing exercises, passive exercises to prevent pulmonary and then cardiovascular complication, right? Okay, we've talked about using Glasgow Coma scale to assess the level of consciousness and all that, right? Apart from that, all other general post-op nursing management is done for this patient. Your nail per should be monitored till bowel sounds return, right? And then when the wound is open, it means that it should be dressed by the nurses, right? So you dress the wound using aseptic techniques, right, to prevent infection, introducing infection that can lead to meningitis and other complications. Then you have to also assess for signs of infection. You can do that by checking the temperature and then assessing the appearance of the wound and all that. Okay. And then you have to also monitor for seizure and then manage appropriately if there is seizure attack, right? And then apart from that, sometimes depending if patient have difficulty in swallowing, an NG tube may be passed to feed the patient, or a gastrostomy feeding may be done. So as a nurse, you feed the patient either through the NG tube or the gastrostomy tube, right? Complications include hydrocephalus, seizure, increase intracranial pressure, sometimes meningitis, encephalitis, etc. Right? After the surgery, there can be bleeding also after the surgery. Right? So most of the time you manage the patient to prevent some of these complications. Right? You manage patient to prevent some of these complications. I talked about the nursing diagnosis, right? So you have to know how to manage the patient under each of the nursing diagnosis, right? Including risks for infection, altered body temperature, right? Altered cerebral tissue perfusion and others. So know how to manage the patient under each of the nursing diagnosis, right? Spinal cord injury has been given as an assignment, so from next week you have to start with your presentations, right? Okay, so we will end the central nervous system here, right? Thank you.